Can hear us. Day one of Epic. We are going to survive, but it's been a day. All right. It is my absolute pleasure to introduce Dr. Sarah Little, who's going to talk to us today about optimizing induction of labor. Dr. Little did her undergraduate work at Harvard, went to UCSF for medical school, and came back to us to do her residency and fellowship at Brigham and Women's Hospital, where she served as faculty for many years. I was lucky enough to recruit her over here after she had been the director of clinical research for MFM at Brigham and Women's. She came to join us as the associate chief of the division. She is a nationally known expert in kind of obstetric management and currently serves on the ACOG Obstetric Clinical Consensus Committee, as well as SMFM editorial board committee. So thrilled to hear about this. Seems like a simple topic, but I think it's very complicated, as we all know. So thank you so much, Dr. Little. Take it away.
Excellent. Thank you so much for having me. It's a topic that's near and dear to my heart. So I love talking about labor induction. So I'm excited to be with you all this afternoon, even if it is on Epic Life Day. So in terms of disclosure, so I've had some prior research funding from Hologic, the company that makes FFN, for some research-related grants, and from Medisem, through the company that makes Dilapan S, and Pulse & More, which makes a handheld ultrasound device. But those I feel sort of pale in comparison to my real disclosure, which is I have been induced twice, right? So that's my son on the left, Charlie, who's now 5, and my daughter on the right, Elizabeth, who is 4. And, I think in OB, we have the unique perspective that we have either given birth or have loved ones or friends or relatives who have given birth. So unlike maybe some other fields like, GI or oncology, where the experience of the doctor is not as often that of the patient as well, we do have that. So certainly I have my own thoughts and feelings about induction, given that I was induced twice that both ended with a vaginal delivery and, so I've experienced some of the agents. And in terms of the objectives and key points, it is to understand that labor induction does not increase the risk of cesarean delivery. So we'll talk about that a bit, which I think is, people have a general sense of that, and most people have read the ARRIVE trial by now and understand the key findings, but we'll just review a little bit of the history of that and what that really means. And then we're going to explore shared decision-making around elective induction for patients and, what you have to include for that and what that really looks like. And then we're going to spend most of the time thinking about ways we can optimize the labor induction process, things we can do to make it as efficient and equitable and streamlined as possible, which I think is what a lot of people are especially interested in doing. All right, so we'll start with a case. As we're giving the whole presentation, we'll think about this patient in your practice, right? So she's a 32-year-old G1 at 38 and 2. She comes in for her routine OB prenatal visit. She's had an uncomplicated pregnancy so far with a normal survey, past her GLT, no significant past medical history, past surgical history. The heart rate is normal in the office. The fundal height is appropriate. Her blood pressure is normal at 115/72. You check her cervix because she wants to know, and she's closed, long, posterior. And then she, of course, brings up at this point, what do you think? My friend was just induced at 39 weeks. Is this something I should be induced to, or something that we should think about? All right, so keep that case in mind. And then just a little bit of background on labor induction in the US. I think as we're all very well aware in the obstetric field, that the rates of induction across the US are rising and have been for the past 40 years, right? So this is looking back at 1990. The dashed line is for all gestational ages. And you can see that was down here in 1990. That was right around 10%. And already by 2012, which is already over a decade old, but by that time it had already doubled and was around 20%. And this rate has just continued to go up. These are all, from the National Vital Statistics. These are all still pre-COVID, and it's only gone up more and more post-COVID. But you can see, 2016 through 2020, we're reaching about 30 to 35% of all births in the U.S. start from an induction. I think that the thing that really has driven a lot of the conversation around induction is this fear that we were increasing the cesarean delivery rate. And, this sort of made sense as the rates of induction were rising in parallel with the rates of cesarean delivery in the US. So during the same time period, they were going up. And that story really made sense, right? We're sort of over intervening. We're, starting these labors off by an induction. We're sort of medicalizing the labor process. And the end result of that is this increase in cesarean delivery rates. So if you think back to our case, this healthy 32-year-old G1 with a closed cervix, probably not that long ago, if she asked you if she should be induced, the first thing you would have told her about is maybe not, because maybe it's going to increase your risk of cesarean delivery, right? So the ACOG practice bulletin, this is an older one, back in just 2009, said that, nulliparous women undergoing induction of labor with unfavorable cervixes should be counseled about a twofold increased risk of cesarean delivery. And in fact, right, when the Choosing Wisely campaign first put out its recommendations from ACOG, that one of the top 5 things that we shouldn't be doing as OBGYN providers was scheduling elective inductions between 39 and 41 weeks unless the cervix was favorable. So this has sort of been a long tenet of our OB practice that I think we had a little bit wrong, right? Because our intuition and really the retrospective data fooled us, right? We are comparing apples and oranges. So we are always comparing women who are induced at a particular gestational age to women who are not induced at that same gestational age. Controlling for as many factors as you could possibly control for. And, the BMI, the age, the indication, and controlling for everything we could, it looked like being induced had about a twofold increased risk of ending with a C-section. But, right, this comparison was false. It was comparing apples and oranges, right? Because you can't choose to be induced, right? And in fact, the choices between being induced at a certain gestational age, say 38 weeks, or not being induced at 38 weeks. But that doesn't mean going into spontaneous labor at 38 weeks. That would be lovely. It means expectant management, right? And during expectant management, you could go into spontaneous labor, but you could also get to 41, 42 weeks and end up needing to be induced anyway, or develop preeclampsia or vaginal bleeding or decreased movement and need to be induced, or just having higher gestational age in and of itself is a risk factor for cesarean delivery. So, really the choices between induction and expectant management. And when people looked at it that way in the data, it didn't look like it held true as much that induction was associated with an increased risk of cesarean delivery. And in fact, even before ARRIVE, there were several RCTs where the intervention itself was an induction, right? And these weren't in low-risk populations. They were in specific subsets, like a post-dates population or an LGA population. But for all of them, you can see this column here. This is the C-section rate for those that were induced versus the C-section rate for those who were managed expectantly. And these women were randomized to one group or the other. And for all of them, right, the rate of cesarean delivery is no higher for those who are induced. And in fact, in the largest one, in the post-dates population, it's a little bit lower if you're induced. And when people did a meta-analysis and put these all together, there's about a 10% decrease rate of C-section for women who are induced. So it was already people were starting to question that sort of well-held belief that induction increased the risk of C-section well before ARRIVE. But then when ARRIVE came out, I think this really changed our view on the risk of C-section after induction. So, ARRIVE came out in August of 2018. And just to review for everyone, the summary of the ARRIVE trial, right? So this was 41 hospitals across the US. This is the MFMU network. 6,000 women were randomized to either induction or expectant management. And these were low-risk nulliparous women. If they were randomized to induction, they were induced between 39-0 and 39-4. And if they were randomized to expectant management, they waited it out until at least 40-5, and then the recommendation to be induced before 42-2, so somewhere within that window. The primary outcome was actually a neonatal composite. And that was no different between the two groups. It was 4.3% for those who were induced versus 5.4% for those who were expectantly managed. But this didn't quite reach statistical significance because the pre-specified p-value was slightly less than 0.05. So it didn't reach the pre-specified p. So it was the overall study had a negative finding or didn't show a difference. But some of the key secondary outcomes did show a difference, right? So the cesarean delivery rate was lower for those who were induced at 18.6% versus 22.2%. So about 20% lower for women in the induction group. And the other secondary outcome that was significantly lower in the induction group was hypertensive disorders, right? At 9.1% versus 14.1% for those who are expectantly managed, which is really quite high for women, a 5% absolute reduction in the risk of hypertensive disorders of pregnancy through labor induction. But I think a lot of people have wondered how this will play out in the real world, right? So outside of a research setting, and to be fair, right, the MFMU is a large group of hospitals and all different practices and practice models, and was a sort of a pragmatic randomized control trial. They didn't tell people how they had to be induced, but the intervention was just to be induced or not. So, I do think it has some generalizability outside of the research world, but whenever you are putting, research findings into clinical practice, the question is sort of how is this going to play out, right? Is it going to be the same when we're doing this outside of a research study? Do inductions really not increase the risk of cesarean? Do they potentially lower the risk? So this is a study I did with one of the fellows who's going to be joining our group actually at the BI soon, Taylor Freret, as well as one of the graduating fellows that I worked with before at the Brigham, Rachel Wood, and we were using an interrupted time series. So looking at rates of labor induction across the US before and after the publication of the ARRIVE trial. So the ARRIVE trial, the 3 months surrounding the ARRIVE trial are in this grayed out column here. And then the top line is the rate of cesarean delivery before and after, and the bottom line is the rate of induction before and after. So you can see that the rate of sort of elective or non-medically indicated inductions, and we're in a low-risk population, significantly increased. So you can see the line here on the bottom, the blue solid line. We would have expected it to continue along the blue dotted line, but instead we see sort of a break in the data, and there's a one-time bump up here, as well as a change in trend. So the rates of induction went up significantly, and then the slope or the rate of change of induction also went up. So even though the trend already existed in the US before the ARRIVE trial, it was really a different trend after that we can sort of attribute to the ARRIVE trial. There was a one-time bump up as well as a change in slope, and this was similarly paralleled by the cesarean delivery rate. So you can see it was relatively flat before the publication of the ARRIVE trial, and then after the ARRIVE trial, you would have expected it to stay in the dotted line, but instead we see this gold line here. So there was a one-time small bump down as well as a change in trend. So it does look from this interrupted time series that, in the real world, sort of the effect across the US was that there does seem to have been a bump up in labor inductions in a low-risk population. And this is associated with a small but significant decrease in cesarean delivery in this group. So back to our case, the healthy 32-year-old G1 with a closed cervix, should she be induced at 39 weeks, right? So that's the question. Our society guidelines are really to engage in shared decision making around this, right? So both SMFM and ACOG, state that best practice is a collaborative discussion with shared decision making for patients around elective induction. Right. So what does that really mean? There's all sorts of different ways of making decisions with patients. A sort of paternalistic model where you give information and recommendations, or informed medical decision making where you sort of data dump information and the patient decides. And then a shared decision-making model, right, where you're sharing information and recommendations, but you're also eliciting values and preferences from patients. And there's this sort of iterative process together where as you learn more about patients' preferences and values, and they learn more about the data and sort of general recommendations, that you guys sort of as a unit, as a provider and patient unit, make a decision together. Right. So what do you need to do, good shared decision-making around elective induction? First of all, you have to be able to provide, reliable, accurate, and adequate information to patients. I think in the past, like I said, we often talked about the risk of induction being an increased risk of cesarean delivery, but I really firmly believe you can't put that in the risk column anymore. And in fact, a small bump down in the rate of cesarean delivery is really actually potentially in the benefit column, or at least I would, when I'm talking to patients, I say that, inductions, don't change the rate, their underlying risk of cesarean delivery, especially when done right and patients and providers are patient. But it doesn't mean that inductions don't have any risk, right? Certainly they're a lot longer, right? In the ARRIVE trial, the average time on L&D was 20 hours for women who were induced versus 14 hours for women who were expectantly managed. So about 6 hours less in the expectant management group. But there are other benefits to being induced, right? Fewer outpatient visits, less hypertension. And then I think where, the informed and shared decision-making process really comes in is about this thought about satisfaction, what patients want, and the value elicitation process, right? So, some questions you can get at to understand patients' values and their thoughts and feelings about induction is really, right, how important is it to them to try to elicit that for labor to start on its own? Or how important is them to have control over the timing of their delivery, right? Do they have things in their life that they have to coordinate, or transportation? Or are they super uncomfortable and want it to be over with? So, I think that understanding how much they value going into spontaneous labor, which certainly has a lot of value for patients, versus understanding how much control they want to have in the process is sort of an important discussion to be having with patients to understand where they're coming from and their values around induction. So back to our case, the healthy 32-year-old who wants an elective induction, or cervix is long and closed. You guys talk about the risks and benefits, and find out that it's not particularly important for her to go into spontaneous labor. And in fact, she lives an hour away. She's very nervous about going into labor, wants to have some control over it, and that has value to her. And she, very much wants to be induced. Great. But, I think the next real question that most people have is like, can your hospital accommodate it, right? It's certainly, as I was saying, like a lot longer to be induced, and it's resource intense, and a lot of hospitals just don't have the capacity to accommodate elective inductions. So do we need to think about rationing them, right? And how do you do that in a reasonable and equitable fashion? All right, so I tried to set up a poll here. We'll see if this works, but I want to know who people prefer to induce. If you had a choice between patient 1, who's a nulliparous patient, and she has a BMI of 42, she's 39 weeks, and her cervix is closed and long, would you rather induce her? Or would you rather induce your multiparous patient, patient number 2, who has a BMI of 23, is 40 weeks, and has cervix who's 3 and 50? All right. So, oh, good. Yes, it's working. People are voting. Let's see. All right. Excellent. Okay, I think most people have voted, and it looks like people have landed at about 75% of people chose patient 2, and 25%, or 22% now have chosen patient 1, which is exactly what I was hoping, right? It was sort of to trick people into choosing patient number 2, which I think is like where we often go. So I'm going to end the poll here. Okay. Let me see. All right, get back to this, right? Because this is my like particular soapbox, right? Is that as OBGYNs or as obstetric care providers, we often think about like the ease of the induction itself, right? And that makes total sense, right? You're sort of already projecting like a day or two into your induction, things aren't going anywhere. And, the nurses are sort of looking at you and saying, why did we induce this patient in the first place? The patient sort of questioning why she was induced in the first place. You're worried she's going to end up with a C-section and sort of blame the whole process of the induction, right? And you're thinking about the, several days she's going to be on L&D. And like, of course, you'd rather, induce the multiparous patient with a favorable cervix. That seems like the no-brainer, right? But really, like, if you think about it, the risks of expectant management are like the risks of increasing gestational age, right? All of these things are happening because patients are getting further along, right? The risk of cesarean delivery, preeclampsia, stillbirth. And really, the only benefit to staying pregnant, right, is unless you're, someone who loves being pregnant, maybe, but really, truly, the only benefit to staying pregnant after 39 weeks is that you might go into labor, right? It's the chance of spontaneous labor. If people value going into labor on their own, that they might do that if they stay pregnant. And like on a population level, what you would actually want is, right, the lowest gestational age after 39 weeks with the fewest inductions, right? So what kind of rationing or policies could you make that would get the most patients delivered at the lowest gestational age with the fewest number of inductions? And I think this is where cervical exam really fools us, right? Because I think a lot of us like go to this, the cervix is favorable, the induction is going to be easier, sort of that's the person that we should induce. But in fact, cervical exam is also highly correlated with whether or not you're going to go into spontaneous labor, right? So this is a study I did looking at low-risk nulliparous women after 39 weeks who had cervical exams and showing the rates of spontaneous labor in the upcoming week. You can see if your cervix is unfavorable, which in this study we said was less than a centimeter dilated, they had a 28% chance of going into labor in the upcoming week versus a 57% chance if they were greater than a centimeter. So a threefold increased rate of spontaneous labor. And after 40 weeks, it's similarly 46% if you're less than a centimeter and 81% if you're more than a centimeter. So cervical exam is like very predictive of whether or not you're going to go into labor. So actually those are maybe the people you want to leave alone, right? Because they're the people who are most likely to go into labor if you do nothing to them. Right. And in fact, if you look at the ARRIVE trial, they did do a subgroup analysis on women who had an unfavorable or a favorable cervix, right? So a modified Bishop score of less than 5 or greater than equal to 5. And the effect or the relative benefit of being induced on cesarean delivery was similar in both groups. So 0.85 and 0.83 was the odds ratio. There was no difference between the two groups. So even though overall, women who had a favorable cervix had a lower likelihood of cesarean delivery, the benefit that they got from being induced was exactly the same as the benefit that women got in the unfavorable group. So their overall rate to cesarean delivery was higher, but they still got the same relative reduction in cesarean delivery through induction. So how do you ration them if you don't have space for everyone to be induced? I would argue that we really shouldn't be basing this on cervical exam. And if anything, it should kind of be the opposite, that we should be less encouraging of being induced for those who have a highest chance of spontaneous labor. So a multiparous patient who's contracting a little bit, 3 and 50, and just wants to be done, if they waited it out, their chance of going into labor in the next couple of days is pretty high. Whereas your higher BMI, nulliparous 39-week patient, her chance of going into labor in the next 2 weeks is actually not very high. And she has actually a very high risk of ending up being post dates, right? So needing to be induced at 41 weeks anyway. So maybe that is like exactly the patient that we should be trying to induce now at 39 weeks rather than waiting till 41 weeks. So if we're thinking about rationing, I would argue that at least cervical exam shouldn't be how we do it, right? You shouldn't be only allowing inductions for people with favorable cervixes. And that also, if we're sort of rationing, that we should think about standardized offering, standardized education, transparent systems where for scheduling, allowing people to get in, and sort of critical appraisal of the equitable sort of offering and distribution of elective inductions for sort of this potentially scarce resource at a lot of hospitals. All right, so say your hospital does have the space to induce this patient of yours, this healthy 32-weekers. How can we make it as efficient as possible, right? So certainly if our labor inductions got closer to that 14 hours versus the 20 hours in the ARRIVE trial, that like you're going to have more space for them, higher turnover, less resource utilization of labor floor resources. So what is our best practices around labor induction to make them as efficient as possible? So I'm going to talk through, I think this is where people, a lot of people are sort of interested. I want to spend time talking about different options for improving efficiency. We'll talk about dual agent cervical ripening, the optimal timing for mechanical ripening, so how long to leave Foley balloons or dilapan in, the optimal timing of amniotomy, outpatient ripening, and then sort of pulling it all together towards making protocols at hospitals. So we'll start with dual agent cervical ripening. This is the For Mommy trial. It came out in 2016 by Lisa Levine and her group in University of Pennsylvania. And I think that this probably for a lot of people sort of increased the attention towards this dual agent cervical ripening. And subsequently, there have been sort of many other trials and meta-analyses that have put it all together. But in this was a 4-arm trial, misoprostal alone, Foley balloon alone, or Foley with misoprostal, or Foley with oxytocin. And that top line is the time to delivery. And in general, this meso and Foley arm, or the Foley and oxytocin arm, had about 4 hours shorter time to delivery versus single agents, so meso alone or Foley alone. And this difference was seen both in nulliparous and multiparous subgroups and was statistically significant. This is just showing the survival analysis. As you can see, the dual agents are in the red and the orange, and the single agents are in the blue and the green, and sort of stratify out. And there's shorter time to delivery for those who are in the dual agents. This is a network analysis or a meta-analysis of several different trials looking at Foley and meso versus Foley alone, Foley and oxytocin versus Foley alone, or the sort of the direct head-to-head comparison of Foley and meso or Foley and pitocin. And the time to vaginal delivery or the time to all delivery is about 3 to 4 hours shorter for combined agents versus single agents. And there's no difference here between those two different types of combined agents, so Foley with misoprostal or Foley with oxytocin. And you can see the delivery in less than 24 hours. So you have about a twofold increased 1.8 or twofold increased rate of delivery within 24 hours by using a combined versus a single agent. So I think a lot of hospitals have adopted this practice of dual agent, whether that's misoprostal or oxytocin combined with the Foley balloon for inpatient ripening. Then, another potential area for increased efficiency, I think, is in how long to leave the Foley balloons in or the Cook catheter balloons in. So this is a study, a small RCT I did at the Brigham with one of our now graduated fellows, looking at 6 versus 12 hours of a Foley balloon. So, should we intend to take the Foley balloon out at 12 hours, or should we intend to take the Foley balloon out at 6 hours? There were about like 180 women in this study, and in the 6-hour group, the time from insertion to delivery was about 5 hours shorter than in the 12-hour group, right? So you didn't get much extra benefit by leaving the Foley in for up to 12 hours. And that's because, the change in Bishop score was like identical really between the groups, whether you took it out at 6 hours or took it out at 12 hours, you're sort of getting the same bang for your buck, right? Your cervical exam or the change in your Bishop score was the same at 6 or 12 hours. So certainly there were women in both group who weren't ripe at the end, but there was no difference in the proportion of that if you took it out at 6 hours versus 12 hours. So for me, this is, I think, actually pretty low-hanging fruit for improving the efficiency of labor induction. Sort of no one wants to be there with a Foley balloon in place. And if we can get as much ripening out of a 6 hours versus 12 hours, I think that's pretty universally accepted. So then this has been shown in other trials too, right? So this is one from Israel, about 200 women, 100 multips, 100 nullips. For the insertion time to delivery for 6 versus 12 hours, it's about 4 or 5 hours shorter in both the nulliparous and multiparous group, with no difference in the change in Bishop score like we saw, and no difference in the change in cesarean delivery. And there were lower rates of intrapartum fever with the 6-hour group, so at 2% versus 10%. Another study out of Malaysia, they actually have a couple of different ones, the same group, one in multips, one in nullips, and one in tolacs. And they similarly found that there was shorter time from labor induction start to delivery with 6 versus 12 hours. Though in their study, they did find there were higher rates on the need for additional ripening in the 6-hour group, but overall, still about 5 hours shorter with the intention to take out at 6 hours versus leaving in for up to 12 hours. So I think that's, a potential way of really improving efficiency is to take the balloon out a little bit sooner. What about amniotomy? I think this is the one that has a decent amount of data, but I think a lot of controversy, and a lot of people feel differently about about amniotomy. I think it elicits strong opinions. So this is, let me see here. Let me go back. First, I want to show meta-analysis. So this is combining 3 different trials looking at early amniotomy versus later amniotomy for women who were induced. And they found overall about a 5-hour reduction in the time from induction to delivery, start of induction to delivery, with earlier amniotomy, right? So this was defined differently in the different trials, which is some of the problem. It's very heterogeneous. People have different practices, but overall, the sort of idea of an earlier amniotomy was associated with a shorter time to delivery, and they found no difference in cesarean delivery rates or chorioamnionitis rates. Then looking sort of particularly at a couple trials that have come out since then and weren't included in that meta-analysis. One is a study by Helen Gomez et al., which is a randomized controlled trial of 160 patients. And I like this trial because it is in the setting of dual agent ripening already. So if you're going to already be doing dual agent ripening, what is the added benefit of an early amniotomy? So for these women who are induced, they were randomized to either an amniotomy within an hour of the balloon removal or expectant management. So amniotomy at the provider discretion. On all of these women, as their dual agent, got Foley with misoprostal. And they were started on Pitocin on Foley balloon removal, or they were started on Pitocin while the Foley balloon was still in place if they were contracting too much for further misoprostal. And there was a difference, right? So on average, the women in their early amniotomy group were ruptured when they were 3 centimeters versus 5 centimeters for women in the later or expectant management group. And there was a very significant reduction in the time to delivery for the early amniotomy group. So overall, it was about 8 hours shorter, 11.1 hours in the early group versus 19.8 in the expectant management group. And this difference was seen in both a multiparous and a nulliparous population. And they found no difference in cesarean delivery or chorioamnionitis. Then one last trial I want to go over, because it just came out actually just last month in May of 2024, is a randomized controlled trial of about 150 patients. They were similarly undergoing induction with mechanical ripening with a balloon. They had Foley with oxytocin for multips, or Foley alone for nulliparous women, which was just their hospital practice at the time. and about 50% of the patients were multiparous and 50% nulliparous. And they were randomized to either amniotomy sort of early, so within 2 hours of balloon removal, versus amniotomy later, which was greater than 4 hours from balloon removal. Their primary outcome, there was no difference. Their primary outcome was the time from Foley balloon placement to active labor, which is a bit of a funny primary outcome, but that's what they had pre-specified, and they found no difference between the early or delayed group, though it was almost significant, and it was 885 minutes in the early group versus 975 in the expectant management group or delayed amniotomy group. When you looked at just nullips alone, it was statistically shorter by about 300 minutes, so about 5 hours shorter for those in the early amniotomy group. And there was also, in one of their pre-specified secondary outcomes, was the time from Foley balloon removal to delivery, which is actually a very important and potential, the time interval that you would actually expect to be most impacted by early amniotomy. And that was statistically shorter at 484 minutes versus 587 minutes for women with a delayed amniotomy. And similar to the other studies, they found no difference in cesarean delivery, though it was 17.3% for the early group versus 21.6%, though that didn't reach statistical significance. And there was no difference in a composite of maternal infection, which included like chorioamnionitis, endometritis, wound infection, though almost so. And again, looked lower in the early amniotomy group, 17.3% versus 31.1%. So certainly no difference, or if anything, maybe a slight suggestion of decreased risk in the early amniotomy group. All right, so we'll move on from amniotomy, which I understand probably has the most controversy, at least it has in the before when I've tried to make protocols around induction. I feel like there's lots of thoughts and feelings from both patients and providers on amniotomy. But we'll move next to talking about outpatient balloon or outpatient ripening, which I think is also a really potentially very impactful way of making inductions more efficient. So this is a meta-analysis of 6 trials, or 571 patients that used outpatient versus inpatient cervical ripening balloons. And in general, if you use an outpatient balloon, you had less time on labor and delivery, right? So the inpatient group, 23.8 hours versus 16.3 hours. So a 7-hour difference by using outpatient ripening, and a slightly lower rate of cesarean delivery for women who used outpatient ripening, but no difference in the overall induction time, total inpatient time, PPH or NICU admission. I think a lot of the questions that come up around outpatient ripening is really around its safety. I like the study because it's hard to ever power studies to safety outcomes because of the, fortunately in low risk populations, the rate of adverse events or very significant adverse events is low. But this study looked at women who were actually inpatients, and when they had a single agent balloon in, what were the rates or what were the event rates for adverse outcomes that you wouldn't want to happen at home, right? So this was 8,292 women. They looked at pain and discomfort, bleeding, a C-section for non-reassuring tracing, balloon displacement, so significant adverse outcomes. And they found no really high rates of any of these, right? So the overall rate of any of the adverse outcomes was, at most 0.25%, and the main one was really pain and discomfort. And sort of this critical adverse outcomes that I would think of, like C-section for non-reassuring tracing, which I think is what we're all sort of worried that sort of bad things are happening and patients are at home and were potential things that we could have intervened on if they were here. That rate was extremely low at 0.01%. And that's really probably because Foley balloons have a very low rate of tachysystole, or actually really causing uterine activity at all after their insertion. So it's a low risk thing to be doing at home, and the risk of adverse events during the period of time from balloon insertion to expulsion is actually probably very low. What about outpatient misoprostal? I think people are often very interested in this. I think there's less or more limited data. Though there was a recent retrospective study from Kaiser that was I thought quite good. Actually, had 345 patients who had outpatient meso, and they compared them to women who had inpatient misoprostal at the same study hospitals, and there was a greater chance of having a more favorable exam, right, on arrival if you were in the outpatient misoprostal group. So the chance of being more than 3 centimeters or 3 centimeters or more was about 40% if you got outpatient cervical ripening with misoprostal. They spent less time on labor and delivery by about 6 hours, with no difference in cesarean delivery or chorioamnionitis rates. So, I think that outpatient misoprostal is potentially interesting. I think a little bit less supported by society guidelines, and misoprostal does have more potential for tachysystole or uterine activity. So there is that, but I certainly think there is room for hospitals to consider using outpatient misoprostal as well for cervical ripening. Though, the rates of showing up with a favorable exam are overall lower for outpatient misoprostal versus outpatient Foley balloons, right? So the need for additional ripening here is about 60% for women who got outpatient misoprostal, and it's closer to about 10% in the studies of outpatient Foley balloons. So you probably are going to be needing to do some more additional inpatient ripening if you're doing outpatient misoprostal alone, but I certainly do think there is a potential role for an outpatient misoprostal. So if hospitals are interested in developing an outpatient protocol, I think that there is really no one-size-fits-all model. I think the best protocols are going to be the ones that are, hospitals develop for themselves, right? That take into account their own unique patient populations and constraints and systems and setups. So, but overall, the things to consider as you're making an outpatient protocol, right, is, outpatient ripening in general is done on low-risk women. The definition of what, counts as low risk does vary significantly across institutions, across studies. If you look at multiple studies of outpatient ripening, some are doing them on preeclampsia without severe features, some are not. So I think there are varying ways that you could define low risk. You could be as most conservative as possible or more liberal, but it's sort of up to the comfort level of each individual hospital making their protocols. Whether or not you want to do mesoprostal or mechanical, I would say the majority of hospital protocols for outpatient ripening are mechanical ripening. And then whether or not you need to do additional fetal testing, right? Certainly you do need to confirm, cephalic presentation before you start any induction, but whether or not you need to do additional testing for women, especially if you're having a Foley balloon, varies. Different hospitals have different protocols. I would say like the California, some of the protocols that are out there don't include additional fetal testing unless it was otherwise indicated. But many hospital protocols are including sort of a NST, whether that's done before or after balloon placement, sort of depends a little bit, like I was saying, on your sort of unique situation or setup or where in the hospital or in outpatient facilities and the access that people have to the ripening, and to the NSTs. So if you're a place that, people have to go to a separate place to get their NST, then they could come to the office and get ripening and go home. Or if you're in a unit that has the ability to both place a ripening agent and do an NST, you might place it first and do an NST after. I think this could be, unique to your hospital system. You could use single or double balloon catheters. Dilapan is approved for cervical ripening too, and though expensive, is a potentially interesting agent for outpatient ripening, particularly. Patients need clear instructions about when and if they should remove the mechanical ripening agent, when to return the hospital to the hospital, and really, hospitals need to develop clear processes. Like, what are you going to do if someone starts their balloon outpatient catheter and then there's sort of no space on L&D for continuing the induction. And I think, there's no industry standard to this. And I think that hospitals can make their own decisions about, we want inductions to start within 24 hours, or, I think it's also reasonable to say if the balloon comes out, they're not ruptured, they're not bleeding, they're feeling good movement, or even if they come in for testing and have reactive NST, to think of it more as like a stage procedure, and they'll get in as soon as possible once the space is available. Then in terms of inpatient protocols, candidates for inclusion, like we talked about, sort of dual agent, shorter time, early amniotomy. And many hospitals have developed their inpatient protocols and have published on their experience with them. So this is from Johns Hopkins, which published their experience developing an inpatient protocol, which is, sort of similar to things we talked about, that, it involves here dual agent as the first choice, early amniotomy, so within an hour of mechanical ripening removal, or within 4 hours of starting Pitocin once the cervix is favorable. The main sort of tenets of their inpatient induction protocol. And they showed that by using it, it reduced labor length by about 2 hours with no change in choreo, PPH, or cesarean delivery. Similarly, this is from the University of Michigan, which published on their experience creating an inpatient protocol. It was a QI project that was, they got their hospital level experts to think about what interventions made the most sense, and they really focused on 3 things. So increasing the use of vaginal misoprostal versus buccal, which they had been using previously, more use of combined agents, and early amniotomy, so encouraging amniotomy at less than 4 centimeters. And they showed that post-implementation, after a series of interventions and iterations and educational events, they were able to increase the use of these 3 main evidence-based practices. So the rates of vaginal misoprostal went up from 35% to 68%. Combined agent ripening went up from 31% to 42%. And the use of early amniotomy did increase from 19% to 32%. Similarly, I feel like here probably also, you could see early amniotomy had the lowest to start and the lowest to finish, but they all did significantly rise in their implementation period. And this did seem to result in improved outcomes, so shorter induction time. So overall, the rates, the time on L&D for inductions went down from 22 hours to 18 hours, and this was seen in both a nulliparous and a multiparous population. And they found no difference in cesarean delivery, in infection, or in PPH. And then I think that's also interesting, that I think there's the potential for inpatient protocols to also increase equity. And, as all patients are sort of along the same pathway, and all patients and providers sort of have a shared mental model of the ideal processes for induction. And this study was by Rebecca Ham and her group at the University of Pennsylvania, and they were comparing women who are managed in an RCT with a standardized induction protocol compared to contemporaneous patients who were induced at the same time, but not in that RCT, so not in a standardized induction protocol. And they found that the induction protocol itself seemed to be associated with a significant reduction in cesarean delivery for Black patients, though no difference in non-Black patients. And when you included this interaction term for race and protocol, it was significant, suggesting that, it really did actually improve equity by having the protocol, even after controlling for parity, BMI, labor induction indication, and Bishop score. It seems that having the standardized protocol itself led to improved outcomes for Black women in this study. So back to our case, we already talked about she's a healthy 32-year-old G1 with a long closed cervix. She understands the risks and benefits and wants to be induced. So in my ideal world, since I'm giving this talk and get to be in charge of what happens to her, right? So she's going to be given patient education about the induction process, an opportunity to ask questions. She undergoes outpatient cervical ripening, followed by an inpatient induction protocol per protocol, and of course has a spontaneous vaginal delivery of a healthy baby girl with good APGARs and a 2nd-degree laceration, and feels sort of very satisfied with the process. So that is, of course, everyone's ideal outcome. So in conclusion, I do want to leave time for questions if possible, but to sort of general conclusions in this sort of post-arrive world, I really think that we can no longer counsel on induction and cesarean delivery. And in fact, labor induction does not increase the risk of cesarean delivery and was shown to be associated with a significant reduction, in fact. Though in practice, even when we engage in shared decision-making with patients, we may be limited by capacity. Right, so then thinking about how we can improve the induction process, I think improved counseling is a first and very important piece, particularly around value elicitation, around spontaneous labor. It's a particular area of research interest of mine is how do we understand how patients value spontaneous labor and how do we predict their chance of going into spontaneous labor. I think we can also improve counseling through patient education on induction processes themselves, right? So what does an induction look like? Sharing with patients, just like I was sharing with you today, like what is sort of some of the data around best practices and developing this sort of shared mental model around labor induction with patients and providers. And then how can we improve efficiency? I think making hospital-based protocols that for outpatient and inpatient, and really, again, having this sort of shared mental model around the ideal process. And that doesn't mean that there isn't room for patient and provider preference around different areas of induction and timing and agents and ways that you want to do it. But I think that people should at least be on the same page about what has the evidence, what is the data, what is best practice. And then if you want to deviate from that, that's fine if you have a good reason and that's your preference. But you should sort of understand as a baseline what is best practice and then decide whether you want to deviate from that in your unique clinical situation. And then I think labor induction is really exciting because I think it's an opportunity for a lot of quality improvement and quality improvement projects and has a lot of potential for impacting a lot of patients, right? As we saw at the beginning, a lot of labor start with an induction. So I think there's the potential to really improve the experience for a lot of patients. Right, I'll start answering some questions, but I really do truly love talking about labor induction and we'll be happy to chat with anyone further sort of offline. That's my email address. Happy to answer any questions. And then I think we still have some time here. I can answer some questions on the chat as well. So let me stop this. And let me see. All right. Dr. Lippman, some questions below. Is there data on patient experience with induction? Of course, health systems like efficiency, but do patients? And that's a great question. I think that it's true. And I've heard people say before, like, okay, so they're faster, but like, is that the point of an induction, right? That you get the baby a lot faster. Probably the point of the induction is that you prevent cesarean deliveries and the patients have a good experience. So I think there's more room for this. There is some data, in the ARRIVE trial itself, they use the labor agentry scale to assess patient experience with labor. And in fact, there was improved patient reported metrics in the induction group. But I think there's a lot of room for this in an area where patients can feel very differently. So I think this is also a point where like value elicitation is really important and sort of understanding what your patients value and how much they value going into spontaneous labor. And I think being very clear about that, right? Like that is the benefit of staying pregnant is that you might go into labor on your own. Sort of how do you feel about that? How do you feel about intervening on a pregnancy? How are you going to feel in the end if you end up with a C-section? Are you going to sort of blame the process of the induction if that's where you end up? Because you might have ended up there anyway. So understanding where patients come from. So I think there's more work to be done on this, but there is some work out there. There were a lot of presentations at SMFM this year where patients were some patient-reported outcomes. But I think that's an area for more work and more interest. And then to your point about offering inductions to non-favorable patients, do you see a future where initiation of outpatient ripening could actually decrease the need for inpatient induction? Absolutely. I think there's actually where the goal of our interventions is actually to increase the rates of spontaneous labor and be thinking about how we can decrease the overall rate of inpatient induction entirely. Absolutely. All right, here's another question. What is your BIDMC protocol for outpatient balloon placement? How long do they stay after placement when you bring them back for removal? So right now at the BI, we don't have, hopefully something we're going to be working on and have soon. My experience previously at Brigham and Women's was that we did have outpatient ripening with balloons. And our protocol there, though there's many different protocols that you can find if you look up. Many hospitals have published their protocols. Sort of interesting to see the different ways. But in my experience, what I've done before is that our protocol was that they had an NST. We had a low risk group. They had an NST before placement, and then they had their balloon placed, and they actually went home after that without any additional testing because our NST unit was sort of separate from the clinic where the Foleys were placed. So that was the protocol that we had. And then we tried to bring them back within 24 hours, but that was not always possible. And we asked patients to remove them on their own, especially if they were going to be at home for longer than 24 hours. And to do this, we had like a detailed instructions where we actually just told patients to cut the end of the balloon that's hanging out, right? So if you cut that, it also cuts the water channel, the balloon deflates, and you can pull out the catheter yourself. So we had them remove them themselves at home if it had been in, once it was in for at least 12 hours, and definitely to have it removed by 24 hours. And we tried to have them in to start the next phase of their induction by 24 hours. Interestingly, when we first started the protocol, I had thought that the ideal process would be would place it at night or in the late afternoon and then have them come back in the next morning. But I think actually many labor floors are similar in that there's often a lot of delays with bringing the inductions in first thing in the morning, and sort of found that starting the outpatient ripening in the morning with a plan to bring them in that evening for the induction was actually a way that we were more able to get them in within 24 hours and improved a little bit the patient satisfaction with the experience too, because a lot of patients weren't sleeping really anyway when they had that balloon in. So putting it in the morning and then going on to the next phase of induction before the night was actually a slightly better process for us. But I think this is something that's unique to different hospitals, and you sort of have to understand your own systems and processes and what works and where it's going to be done, and how inductions are scheduled and how easy they are to get in terms of making your own protocol. All right. I think that's all the answers all the questions I see here, and we're closing in on that 6 o'clock. So like I said, feel free to reach out to me over email if you want to talk more. I love talking about induction, and thank you so much for attending. So.